Welcome to Chapter 19, Endocrine and Hematological Emergencies. Be sure that you're logged in to get appropriate credit for this lecture. All right, so endocrine system. The human endocrine system directly or indirectly influences nearly every cell, organ, bodily function. Endocrine disorders are often seen with multiple signs and symptoms. Hematological emergencies are difficult to assess and treat in the pre-hospital setting. All of your actions may save a patient's life in either one of these type of emergencies. All right, so a little bit about anatomy and physiology. The endocrine system is a communication system. What it does is it controls the functions inside the body. It does this through endocrine glands. They secrete messenger hormones. The hormones travel through the blood and to end organs, tissues, or cells that they affect. When it arrives, the message is received and an action takes place. Endocrine disorders are caused by an internal communication problem. If a gland is not functioning normally, it may produce more hormone, which is called hypersecretion, than needed, or not enough hormone, which is hyposecretion. A gland may be functioning correctly, but the receiving organ may not be responding. All right, so glucose and metabolism. The brain needs two things to survive. Biggest one is glucose, okay, and oxygen. Without those two things, we're not going to do so good. So glucose and oxygen are the two primary things that the brain needs. All right, so insulin is necessary for glucose to enter the cells. So remember one thing, insulin does not create, it does not destroy, it does not do anything with sugar, but transport it. It has to put it on its little back and transport it across the semipermeable membrane and into the cells. Without enough insulin, the cells do not get fed. The pancreas produces and stores two hormones, the first one being glucagon and the second one being insulin. The pancreas stores and secretes insulin and glucose in response to the level of glucose in the blood. Now, diabetes mellitus is a disorder of the glucose metabolism, such that the body has an impaired ability to get glucose into the cells to be used for energy. Without treatment, blood glucose levels become too high. In severe cases, it may cause a life-threatening illness or coma and death. If not managed well on a routine basis, it can have severe complications such as blindness, cardiovascular disease, kidney failure. There are three types of diabetes mellitus. Diabetes mellitus type 1 and diabetes mellitus type 2, and then also pregnancy-induced gestational diabetes. There are treatments for diabetes. Usually it's medications and injectable hormones that lower blood glucose levels. If administered correctly or incorrectly, it can create a medical emergency for a patient with diabetes. Low blood glucose levels, which we call hypoglycemia, if unrecognized and untreated, can be life-threatening. You need to know the signs and symptoms of high blood glucose levels, which is hyperglycemia, and low blood sugar, low glucose levels, which is hypoglycemia. Now, in high blood glucose levels, it can result in coma or death. If treatment exceeds a patient's need, it can cause a life-threatening state of hypoglycemia. Low blood glucose levels, or hypoglycemia, can cause death as well. Once you get below about 21 milliliters per deciliter of blood, you can pass out and die, stop breathing. Your brain is no longer getting enough sugar. Hyperglycemia and hypoglycemia can occur with both diabetes mellitus type 1 and type 2. You will encounter many patients displaying the signs and symptoms of high and low blood glucose levels. Hyperglycemia and hypoglycemia can be quite similar in their presentation. Patients usually present with some sort of altered mental status, and they can often mimic what could be considered as alcohol intoxication. Intoxicated patients often have abnormal blood glucose levels as well. Hypoglycemia can develop very quickly if a person takes his or her medicine but fails to eat enough food. The typical patient in hypoglycemia is the patient that got up in the morning, started their routine, went and took their insulin as normal after they tested their blood sugar, because they're testing it on a sliding scale. So they take their blood sugar in the morning, and the blood sugar, say, is 98. They look on their sliding scale and they determine how much insulin that they need to inject into themselves based on having a blood glucose of 98 that morning. After they take their insulin that they've drawn up and given to themselves, what happens is they're supposed to eat. And a lot of times they forget. They go about their day, and then suddenly they have no sugar, no carbohydrates to be processed by the insulin that they've just injected. So that insulin sits around with nothing to carry over into the bloodstream. Because remember, insulin is nothing more than a transport mechanism. That's all it does. It carries the sugar over to the cells. So it has no sugar to carry anything over. So it carried everything it could, and suddenly it's out. So it's just sitting around doing nothing. And now you end up with a low blood sugar. So if a person takes too much medication, resulting in low blood glucose levels despite normal dietary intake, that can happen as well. All hypoglycemic patients require prompt treatment. You don't want to see them get too low and then pass out, because that can be a big problem if you run out of sugar within your body system. The brain depends on it to live. All right, so let's talk very specifically about diabetes mellitus type 1. It is an autoimmune disorder which the immune system produces antibodies against the pancreatic beta cells. What happens here is that you're missing now the pancreatic hormone insulin. With these kind of patients, the onset usually happens from about early childhood through the 4th decade of life. The patient must obtain insulin from an external source. Patients who inject insulin often need to check their blood glucose levels up to about 6 times per day or more. Right, many people with type 1 diabetes have an implanted insulin pump. Those are pretty cool. They're little pumps that you can wear on your side that deliver a certain amount of insulin either on demand or as throughout the day, depending on your dietary settings and how much you're eating throughout the day. It continually measures those glucose levels and provides insulin and correct doses of insulin based on carbohydrate intake at meal times and any snack times that you may have in there. Now, it does limit the number of times a patient has to check their finger stick glucose level, because it's continuously monitoring it internally. Now, these things can malfunction, and diabetic emergencies can develop very quickly. So always inquire about the presence of an insulin pump when you have a patient who is a known diabetic that you're trying to treat. All right, so type 1 diabetes is the most common metabolic disease of childhood. A patient with new onset type 1 diabetes will have symptoms related to eating and drinking. They will have polyuria, which is frequent urination, polydipsia, which is an increase in fluid consumption, polyphagia, which is severe hunger and an increased food intake, weight loss, and fatigue. All right, so when a patient's blood glucose level is above normal, the kidneys begin to kick into place. Their filtration system becomes overwhelmed, and the glucose begins to spill into their urine. When the glucose is unavailable for cells, the body turns into burning fat. When the body burns fat rather than glucose, it produces waste, acid waste, that are called ketones. As the ketone levels go up in the blood, they spill over to the urine as well. That's when you get the very big smell in the urine that it smells like juicy fruit gum, because again, ketones has that particular smell. Now, kidneys become saturated with glucose, and ketones cannot maintain acid-base balance in the body. The patient breathes faster and deeper as the body attempts to reduce the acid level by releasing more carbon dioxide through the lungs. This is known as Kussmaul respirations, and it's very distinct when you see this. They're deep patterns, rapid patterns of breathing. So, if fat metabolism and ketone productions continue, that creates a life-threatening illness called diabetic ketoacidosis, or DKA. DKA can develop. DKA may present as generalized illness, plus it may also have abdominal pain along with it, body aches, nausea, vomiting, and altered mental status, or even unconsciousness if severe. If not rapidly recognized and treated, DKA can result in death. When a patient with diabetic ketoacidosis has altered mental status, you need to ask the family or friends about the patient's family or patient's history and presentation. Get a glucose level as soon as possible with a finger stick using a Landsat and a glucometer. Generally higher than 400 milligrams per deciliter is a patient with DKA. I've seen it as high as 2100, and I tell you, when I walked into the room, the overwhelming smell of ketones was absolutely incredible. This was out at the Air Force Base at the time. And I just will never forget that, how much it smelled like juicy fruit gum. To this day, I don't really like juicy fruit gum because of that. So it's interesting. All right, so diabetes type 2 is a little bit different animal. It's caused by a resistance to the effects of the insulin itself at the cellular level. Otherwise, it doesn't like to transport sugar. The insulin just doesn't carry the sugar over. Okay, so it's a bad transporter. The truck is always full of other stuff. All right, so there is an association with this because of the sugar that maintains or stays within the blood sugar. There's a relationship or an association between obesity and increased resistance to the effects of insulin. That's because the sugar is staying within the bloodstream, so then it goes into the liver, and then the fats have to go somewhere. So anyhow, the pancreas, in this particular case, produces more insulin to make up for the increased levels of blood glucose and a dysfunction of that at a cellular insulin receptor sites. Then insulin resistance can also sometimes be improved by exercise and dietary modification, which ultimately will help the type 2 diabetic overwhelm their signs and symptoms. Usually oral medications is used to treat type 2 diabetes. There is some increase in secretion of insulin, and it does pose a high risk of hypoglycemia reactions. Some stimulate the receptors for insulin, and others decrease the effects of glucagon and decreases the release of glucose stored in the liver. Now, you also have some injectable medications, and insulin are used also for type 2 diabetics, but usually it's controlled by diet and regular exercise. Right, so with diabetes type 2, it's often diagnosed at a yearly medical examination from complaints related to high blood pressure, high glucose levels, so on and so forth, and it's usually at a physical annual exam. Including also patients with recurring infections, changes in vision, and also numbness in the feet. All right, so symptomatic hypoglycemia. Symptomatic hyperglycemia. This occurs when blood glucose levels are very high. The patient is in a state of altered mental status resulting from several combined problems. In type 1 diabetes, it leads to ketoacidosis with dehydration from excessive urination. In type 2 diabetes, it leads to a non-ketotic hyperosmolar state of dehydration due to the discharge of fluids from all of the body systems and eventually out through the kidneys, leading to fluid imbalances. So it's kind of easy to remember non-ketotic hyperosmolar state of dehydration. This is because the only way that the body can rid itself of all the sugars is through ketones that are being released through the kidneys. So with this, it causes excessive urination. So it creates a fluid imbalance, hence the word, the hyperosmolar problem. So hyperosmolar problem or state of dehydration is directly related to the excessive amount of excretion of urine. All right, so if an individual has hyperglycemia for a protracted length of time, consequences of diabetes may be present. All right, so let's get into, we'll talk a little bit more about the glucose levels in hyperosmolar hyperglycemic non-ketotic syndrome, or HHNS. When those blood glucose levels are not controlled in diabetes type 2, that condition does occur. It can develop very, very quickly. Signs and symptoms of HHNS include hyperglycemia. So they're going to have, when you test their blood sugar, they're going to have high blood sugar. They're going to have altered mental status, drowsiness, and lethargy. They'll also have severe dehydration, thirst, and their urine is going to be very, very dark. It's going to have a very specific smell to it, too, as well. Just remember that juicy fruit gum thing. Visual or sensory deficits could be presenting themselves because when you have high glucose, it tends to stick to the lenses of the eye and begins to blur the vision itself. And if it's prolonged, it can actually cause blindness because of that. We have a cat that has that particular problem. Partial paralysis or muscle weakness, also seizures as well. All of these could manifest themselves in HHNS. All right, so higher glucose levels, again, we're back to the hyperglycemia. Higher glucose levels in the blood causes an excretion of glucose in the urine. Patients respond by increasing their fluid intake, which eventually causes them polyuria. In HHNS, the patient cannot drink enough fluid to keep up with the exceedingly high glucose levels in the blood. The urine becomes very dark and very concentrated. The patient may become unconscious or have seizure activity due to severe dehydration. All right, so acute emergencies, this is when the patient's blood glucose level begins to drop. This is the patient in hypoglycemia and must be corrected swiftly. This can occur in patients who are utilizing insulin to manage their blood glucose levels. It can also, when insulin levels remain very high, glucose is rapidly taken out of the blood. It's transporting so much across the cells it can't keep up with it. You're not going to be able to eat enough to manage it. So if glucose levels fall, there may be an insufficient amount to supply the brain. Mental status begins to decline in these kind of patients, and he or she may become very aggressive or display unusual behaviors. Unconsciousness and permanent brain damage can quickly follow this. Common reasons for a low blood glucose level to develop are very, very simple. It's usually that people have taken their insulin, they simply have not eaten. Hypoglycemia develops much more quicker than hyperglycemia. Signs and symptoms of hypoglycemia are very profound usually. All right, so here is a hypoglycemia when it's quickly reversed by giving the patient glucose. You see here on the left, this is your glucose level. As you can see here, it says the number 40. That's in hypoglycemic crisis. 80, between that 40 to 80 is considered as hypoglycemia, but usually it's not in crisis stage. Here at 120, this is normal. So, there's a big range between, normal and the hyperglycemia range. So primarily, when you give glucose orally, when they're down here between the 40 and 80s, it'll boost them back up into the 120s, maybe a little bit more. So all it does is it gives them some sugar reserves that are short term. They have to eat some long-chain carbohydrates before they can be left alone. So many times you'll have a patient that you're treating who's diabetic, hypoglycemic, that you'll give them some oral glucose and they'll say, "Thank you very much, I'm fine." Well, it doesn't end there. You need to make sure that they eat. So if you treat them at home and they're adamantly refusing not to go to the hospital, along with getting your form signed for refusal for transport, you need to go in the kitchen, somebody needs to, and make this person a sandwich. Because if they don't eat, you'll be right back and they'll be right back in the same problem. So remember that, because it's the sugar that we give is very short acting. It's going to burn up very, very quickly. They need long chain carbs in order to survive, for the rest of the day. All right, so back to our assessment portion of it. Remember, and I'm going to beat this in you over and over and over again. Assessment, assessment, assessment. Okay, this is your deal. This is how we do our assessment for patients that are relative to endocrine or hematological type of emergencies. So first is obviously our scene safety. Remember, with diabetic patients, they may have syringes, so they may be around. So be careful, don't get stuck. Be alert for clues that this person's a diabetic, such as if you see, the oral glucose tablets sitting around, those kind of things. That's a clue, okay? Use standard precautions as usual. Question bystanders on events leading to your arrival. keep open the possibility that the patient may have trauma. And these people may not be very cooperative. These patients can also be not only a medical patient, but they could be trauma as well. So determine whether there's a mechanism of injury involved as well as the nature of illness. There's sugar. They could have been on the way to the store. They didn't eat. They took their insulin at the house, and then they passed out behind the wheel because they got hypoglycemic. All right, so forming your general impression, obviously, you got to do that as usual. Look at your airway and breathing. Patient showing signs of inadequate breathing, you need to support their oxygen, especially if their saturation levels are below 94%. Airway and breathing continued. Hyperglycemic patients, remember we talked about this, they have that Kussmaul respirations, and they have that sweet, fruity breath. Again, juicy fruit gum. I'm telling you, the first time you smell it, you're going to go, Jeff was right. This patient smells like juicy fruit. These are all clues and signs that this patient is having hyperglycemia. Now, in your hypoglycemic patients, they will have a normal or shallow type of respirations. You need to manage their respiratory distress as normal. All right, circulatory status, your patients with hyperglycemia, all right, these will be dry and warm. Hypoglycemia, moist and pale. Also, patients with hypoglycemia, symptomatic approach or symptomatic hypoglycemia, they will also have rapid weak pulses. So transport decisions, you need to make sure that you understand that this is an emergency. It's a true life threat, especially hypoglycemia, and that you need to determine what their glucose is and then get them transported or transferred over to an ALS support as quickly as possible. So yes, they need to go to the hospital. All right, so investigate the chief complaint. This is good history taking. History of present illness, because we need to determine whether this patient's truly a diabetic or not. If the patient has eaten but not taken insulin, okay, usually they're hyperglycemic. Okay, if the patient has taken their insulin but not eaten, okay, that's usually relative to hypoglycemia. So put your detective hat and you'll be fine. You'll figure this out very quickly. Carefully observe signs and symptoms to determine whether hypo or hyperglycemia exists. Sample history. Okay, here's all good stuff. Do you take insulin or pills to lower your blood sugar? Do you wear an insulin pump? Have you taken your usual dose? Have you eaten normally today? Have you had any illnesses or any unusual amounts of activity or stress? Because remember, illnesses, activities, and stress can cause sugar-related problems, sugar-related changes. So be sure that your actions, especially infections like urinary tract infections, is they can also mimic hypoglycemia. In patients that are septic, because they have a fever, they're burning more sugar than they normally would. All right, so physical exam, assess unresponsiveness when you suspect diabetes related, focus your mental status, ability to swallow, and protect their airway. Go ahead and do your Glasgow Coma Scale score too, so you can see if they have marked improvement after you treat them with, with some glucose. Vital signs, obviously, glucometer, we need to test it. If it's below 40, you got a problem, okay? If it's up between 40 and 80, you still have hypoglycemia that's present, and you could very easily correct that with some sugar or some long-chain carbs. So hypoglycemia, we talked about respirations are normal to rapid, pulses weak and rapid, and the skin is typically pale. This is your hypoglycemia. And then your hyperglycemia, this is respirations may be deep and rapid. Pulse may be rapid, weak, and thready. The skin is usually warm and dry with a normal blood pressure. Glucometers, need to test that blood sugar, okay? Normal, non-fasting adult and child blood glucose levels run between 80 and 120, okay? Neonates should be above 70. All right, so interventions, reassess the patient with diabetics frequently, with diabetes very frequently. For hypoglycemia, okay? Conscious patients who can swallow, take glucose tablets or drink some juice containing sugar. It's very simple. Just take, a glass of orange juice, apple juice, dump in, somewhere between tablespoon to 2 tablespoons of sugar and stir it up really, really good and have them drink it. Very easy to do. If they don't have any glucose tablet, if you can find some cake made in the house, that works as well, and it tastes a lot better, and it's a little bit less. Or if you carry on your vehicle or in your junk bag, which most of us do, gel preparation or sugar drink that we carry, with inside of our junk bag, the oral glucose stuff. All right, so if they are unconscious, all right, don't give them anything by mouth at this point because they need intravenous IV glucose or an IM injection or intranasal injection of the drug glucagon. This is beyond the EMT levels, but it's kind of interesting. We call it the wake up effect, the God effect, whatever you want to call it. You come in, this person is unconscious and unresponsive. You start a little IV on them, you give them some sugar, bam, they're wide awake. And the family goes, ah. So anyhow, yep, that's the way that works. When in doubt, consult medical control. Okay, if you don't know what to do, you need to call in for your medical director and find out what their instructions would be. If unable to test for blood glucose value, so just perform your thorough assessment. So, for instance, the batteries are dead in your glucometer. Whoops, bad on you because you didn't check it out before you started your day. Contact the hospital to help sort out the signs and symptoms, and then coordinate and communicate and document with your supervisors and maybe a transport unit, to get them as soon as possible. When in doubt, just administer oral glucose if they are conscious. If your glucometer does not work, you're not going to do them any harm because they'll burn that sugar off no matter what. All right, so here's your glucose gels. Here's two different forms of it. This is probably lemon flavor, and that's probably cherry flavor. Either way, you're going to get the opportunity to see what this tastes like because we do that every semester to every student. So you'll get to taste what this stuff tastes like. It's not that good, but it's not that bad either. Anyhow, it could be a life-saving type of intervention, so do remember that this is good stuff and we carry it in our bags. All right, so contraindications is really just the inability to swallow and unconsciousness. Wear gloves before putting anything in the patient's mouth. Follow your local protocols for glucose administration and reassess them frequently. So the presentation of hypoglycemia could also be a presentation with seizures, and they should be considered very, very seriously, especially if a patient with chronic seizures. Hypoglycemia is a possible cause of seizures, but it's usually not. You usually catch them. There could be some underlying cause as well. Though brief seizures are not harmful, they may indicate a potentially life-threatening underlying condition. Very simply, for management, ensure that the airway is clear. Place the patient on her side. If there's no possibility of cervical trauma, do that. Do not place anything in the patient's mouth, such as a bite stick or oral airway. Have suction equipment ready in case the patient vomits. If the patient is cyanotic or appears to be breathing inadequately, provide oxygen or artificial ventilation, and then transport as promptly as possible. All right, so altered mental status, there comes several different levels. This may be from other conditions. It may be caused by complications of diabetes. Hypoglycemia and ketoacidosis causes, altered mental status. Use the mnemonic A, E, I, O, U, and TIPS. Always suspect and check for a low blood glucose in a patient with altered mental status. Management, we just need to ensure that the airway is clear, be prepared to provide artificial ventilations as necessary, and be prepared to suction if the patients vomit, and then provide prompt transport as soon as possible. All right, so hypoglycemia versus a neurological dysfunction problem. Occasionally, patients with diabetic emergencies are thought to be intoxicated. Diabetic patients sometimes can be confined by police officers, because they think they are intoxicated. This could cause a patient to be at risk. So need to assess them appropriately and try to get your glucose done as quickly as possible. And then also look for an emergency medical identification bracelet, necklace, or a card. This may help to save the patient's life in such situations. A blood glucose test is performed at the scene if protocols allow, or in the emergency department that will identify the real problem. Be alert to the potential problem for diabetes and alcoholism as a coexistent type of problem in a patient. So relationship to airway management and hypoglycemia, remember they may not have a gag reflex and vomit, or their tongue may obstruct the airway because their glucose is so low. Carefully monitor the airway, place the patient in a lateral recumbent position, and make sure that suction is readily available. All right, so hematological emergencies. As promised, we started this out as endocrine emergencies. Now we're going to close it up with our hematological emergencies. Hematology is the study of blood-related diseases. 3 disorders that can create pre-hospital emergencies are sickle cell disease, hemophilia A, and thrombophilia. These you need to be familiar with. Right, so continue on. Blood is made up of components. Components consist of erythrocytes, leukocytes, platelets, and plasma. Each of the components of the blood serves a purpose in maintaining the body's homeostatic balance. Red blood cells, RBCs, or erythrocytes, you can call them either way, they contain hemoglobin. Hemoglobin carries oxygen to the tissues. Then we have white blood cells, WBCs, or what are also considered leukocytes. They respond to infection and collect dead cells for their correct disposal. Platelets, they assist in forming a clot to stop bleeding. And then plasma serves as the transport medium for blood components, such as proteins and minerals. So sickle cell disease. Sickle cell disease, also called hemoglobin S disease, it's an inherited blood disorder that affects red blood cells. It is found predominantly in people of African, Caribbean, and South American ancestry. People with sickle cell disease have misshapen red blood cells that tend to be, they lead to being dysfunctional in oxygen binding and unintentional clot formation. They kind of look like little pink bananas instead of being little round Werther's cough drops. If you know what Werther's, I guess they're really not cough drops, they're candies. They have a little round shape and a little divot in the middle of it. That's what your red blood cells look like. Imagine a banana, the shape of a banana. That's what sickle cells look like. So clots may result in a blockage known as vaso-occlusive crisis. It can result in hypoxia and substantial pain and also organ damage. All right, so with the sickle cells have a short lifespan, resulting in more cellular waste products in the bloodstream and contributing to sludging or clumping of the blood. With this, we run a higher risk of forming clots and putting those into the brain or into the heart. So maintaining hydration is important. It's as insufficient hydration leads to the more clumping of the blood itself. Complications associated with sickle disease include anemia, gallstones, jaundice, splenic dysfunction, and also vascular acute occlusion with ischemia. Here we go. I didn't know that they had this picture in there. This is great. Okay, now see these guys? This is your normal blood cell. Okay, notice it has a little nice round shape to it. It has a little divot in it. And then this is a sickle cell. Look at it. It looks like a little pink banana. Okay, so the problem with these guys is because they're mouse-shaped, they stick to the nice red blood cells. Okay, and they don't allow for oxygen to bind to them or to the cell that they're sticking to. So as they start sticking to other cells, that's what causes that clumping. And so when you have that situation, it's taking up more space than the plasma. So then when that happens, the clot formation is more prominent. That's why dehydration occurs as well. First off, they don't feel well, they hurt, so they're not doing much oral intake. So we promptly start IVs on these people and give them a lot of fluid in order to rehydrate the plasma to reduce the amount of clumping inside of the vascular system of these oddball-shaped cells. So many complications are very painful of the sickle cell, and it's potentially life-threatening. The patient is also more susceptible to infections as well. All right, so clotting disorders. Let's talk about hemophilia. It's rare. Only about 20,000 Americans have this disorder, in the United States. Hemophilia A affects mostly males. It's people with hemophilia A have a decreased ability to create a clot after an injury. So to create a clot after injury, which in these particular circumstances, especially in large injuries, can be life-threatening. Patients with hemophilia A typically will have an intravenous factor of V1 replacement infusions. What happens here with this infusion, they're adding clotting fibrogen mechanisms back into the blood, which help that blood to clot. And without these transfusions, they can end up being in trouble throughout their life on a weekly basis, if not, on a monthly basis, if not a weekly basis. So they'll actually go and get these at a transfusion center. All right, so this one is talking about thrombophilia. It's just the opposite. It's a disorder in the body's ability to maintain the smooth flow of blood through venous and arterial systems. This is due because of the concentration of particular elements in the blood that creates clogging or blocking issues. Otherwise, there's too much clotting. All right. Thrombophilia is a general term for many different conditions that result in the blood clotting more easily than normal. It's inherited as a genetic disorder. There are medications or other factors that affect this. Also, patients that have cancer can also have a form of thrombophilia. Clots can spontaneously develop in the blood of the patient without any warming whatsoever. All right, so deep vein thrombosis, or DVT. This particular is a common medical problem in patients that have a sedentary lifestyle and in patients who have recent injury or surgery. You may encounter several methods to prevent blood clot formation, to include blood thinning medications that patients may take, also patients that may also have compression stockings, and then mechanical devices. All right, so clotting disorders, DVT, and continued the risk factors of these kind of patients and treatment. A lot of these people get anticoagulation therapy. This is an in-hospital IV medication, and then ultimately they'll be transitioned over to oral medications before discharge. They also may have a self-administered injectable or oral medication like Lovenox as well. Oral medications are typically administered at least 3 months after diagnosis of a DVT. A clot from a DVT can travel from the patient's lower extremity to the lungs, causing a pulmonary embolus, which, unless you get to a hospital right away, you'll die from that. All right, so with these patients, as we talked about in every lecture, we get the little scene size up in the patient assessment portion of it. This is for the hematological patient. First off, on scene safety, most sickle cell patients who have had crisis before, they know it. They will tell you, their parents will tell you that, my son or my daughter has sickle cell. Bottom line is just, wear your gloves and eye protection at a minimum. Consider ALS support, because this is, again, a very painful event. If you need to transport, it'll be helpful that they're transported by an ALS unit so they can give them fluid and pain management. Remember that sometimes these patients can also have trauma because of their age group. Perform cervical spinal mobilization as necessary. Get your general impression done. Make sure they have adequate breathing and airway. High flow oxygen, 12 to 15 liters. Sickle cell crisis may have poor respirations or slowing respirations, and also signs of pneumonia. So be sure to give them high flow oxygen. So circulation in sickle cell patients, they're going to have an increased heart rate. In hemophiliac patients, be assured that, or be alert for acute signs of blood loss. If they're losing blood from somewhere, you need to know it. Note any bleeding of any unknown origin. And then be alert for signs of hypoxia. Make your transport decisions and get them to a hospital right away. Investigate the chief complaint. Obtain history of present illness from responsive patients. Be alert for any physical signs indicating sickle crisis. Ask about, is the pain isolated in a single location or felt throughout the body? Usually your sickle cell patients will complain of pain everywhere. Is there any visual disturbances? Nausea, vomiting, any abdominal cramping, chest pain, or shortness of breath? Obtain your sample history. Talk to your mom. Talk to their mom, their dad. If they're an older patient, try to get as much relative history you can from sample history. Ask the patient, have you had a crisis before? When was the last time you had a crisis? How long did your crisis last, and did it resolve favorably, or did you have to be admitted to a hospital? Is there any recent illnesses outside of your crisis, or any unusual amount of activity or stress in your life? Secondary assessment, physical examination, focus on major joints, because this is where the sickle cells tend to clump and they become a lot of, that's a lot of pain that's associated with that. Evaluate and document mental status using your ABPU, get your vital signs, look for signs of sickle cell crisis, and then use your pulse oximeter if available. Reassess vital signs frequently, evaluate interventions in your reassessment, supply supplemental oxygen by non-rebreather, communicate with the hospital staff for continuity of care, and document early. All right, so emergency medical care for hematological disorders, it's mainly supportive and symptomatic. There's not a whole lot you can do pre-hospital wise. Emergency care is mainly supportive and symptomatic, especially for patients with inadequate breathing or altered mental status. You need to give high flow oxygen, 12 to 15 liters per minute by a non-rebreather, put them in a position of comfort, and transport them as soon as possible. All right, thank you very much for attending this particular lecture. This is your review, so you just go ahead and go through that as necessary. Be sure that you clock out to get proper time or proper credit for this lecture, and do your Quizlet as soon as you finish this lecture. All right, so thank you very much, and have a good one. We'll see you next time.